Todd Damrow was the state epidemiologist for the Montana Department of Public Health and Human Services, MDPHHS. He holds a PhD and a Master of Public Health, and in his role he oversaw infectious disease surveillance and other public health functions in Montana. For example, he was referenced in a 2006 news article discussing a rise in waterborne illness in Montana. Christine G. Hahn, MD, was the state epidemiologist and medical director of the Division of Public Health at the Idaho Department of Health and Welfare. By 2021, she had nearly 25 years in that role and was nationally recognized, receiving the Pump Handle Award from the Council of State and Territorial Epidemiologists for her public health leadership in Idaho, including work beyond infectious disease into lead exposure and opioid overdose prevention. This 2001 paper describes how public health officials in Montana and Idaho dealt with massive, 3-week rainbow family gatherings of up to about 23,000 people camping in remote national forests with no running water, sewage systems, or formal medical services. It explains that such events can easily lead to problems like food poisoning, contaminated drinking water, injuries, fires, and disease outbreaks, especially because the group is informal, suspicious of government, and highly mobile. To manage this, local and state health departments work closely with the U.S. Forest Service, law enforcement, hospitals, and an on-site volunteer clinic called CALM to monitor health issues, give safety advice, test water, encourage better sanitation and food handling, and plan for medical evacuations and wildfire risks. Public health workers visited the site regularly, build trust with participants and volunteer healers, and set up ways to detect possible disease outbreaks, such as providing stool sample kits and sharps containers. The paper concludes that the gatherings ended without major public health disasters largely because agencies coordinated well, adapted to an unusual setting, respected each other's roles, and stayed flexible and cooperative in working with a non-traditional community. The Rainbow Family of Living Light is a loose, leaderless group that grew out of the 1960s counterculture and gathers every summer for a 3-week event called the Gathering for World Peace and Healing of the Earth, which draws tens of thousands of people to remote national forests. The paper focuses on the 2000 gathering in Montana and the 2001 gathering in Idaho, both held far from towns and without basic infrastructure such as water systems or sanitation. The purpose is to explain how public health officials manage these large, isolated events and to outline what they learned about protecting community health in such difficult environments. The two gatherings were massive events held deep in the forests of Montana and Idaho, with about 23,000 people attending in 2000 and more than 19,000 in 2001. Both sites were far from towns, often 50 to 100 miles away, and reaching them required a long walk over rough, uneven ground. The locations had no built-in services, making them challenging places to host such large temporary communities. The people who attended were highly unconventional and moved around frequently, often using nicknames instead of real names. They resisted formal rules, avoided organized structures, and were wary of government officials, which made coordination and communication difficult. The gatherings operated without leaders, relying instead on an informal, communal style that shaped how the entire event functioned. The 2000 gathering in southwest Montana was a huge national Rainbow Family event where about 23,000 people camped deep in a remote forest with no running water, no bathrooms, and no official medical services. The site was far from towns and took a long hike to reach, so public health workers had to walk in regularly to check food areas, drinking water, and toilets. People drank water piped from nearby streams, which lab tests showed was contaminated, so health workers urged everyone to boil or treat their water. Dozens of volunteer kitchens cooked without refrigeration or temperature checks, and simple hand-dug latrines served as toilets. A volunteer clinic called CALM handled most medical needs, and public health staff built friendly relationships with its volunteers to share information, offer safety talks, and prepare for possible disease outbreaks. Despite the difficult conditions and the group's informal, leaderless style, the event ended without a major health crisis thanks to steady cooperation between the Forest Service, health workers, and volunteers. The 2001 gathering in central Idaho brought more than 19,000 people into an equally remote forest location with the same lack of basic services, but this time drought conditions created a serious fire risk. Because the only access road was a narrow dirt track, evacuation wasn't realistic, so the Forest Service identified safety zones where people could go if a wildfire broke out, and public health workers helped spread that information. Communication was poor, so law enforcement mapped out helicopter landing areas, and several people were airlifted out for medical emergencies such as heart attacks, seizures, and accidents. Food was cooked in volunteer kitchens without refrigeration, toilets were hand-dug pits with improvised washing stations, and untreated stream water was used for drinking. Most medical care again came from the Calm Volunteer Clinic, which treated everyday problems like stomach illness, injuries, and sunburn. Idaho's public health districts worked within the multi-agency command structure to watch for health problems and offer guidance, and the gathering finished without major outbreaks or disasters because of ongoing cooperation and careful monitoring in a challenging environment. Public health teams faced major practical challenges because the gatherings took place in remote areas with no sewage systems, no clean running water, and very limited sanitation options. With thousands of people crowded together, makeshift toilets and untreated stream water created a high risk for illnesses caused by contaminated food and water. The sheer number of attendees living in close quarters increased the chance that any sickness could spread quickly. Past experience also showed how serious these risks could be. In 1987, a rainbow family gathering in North Carolina led to a large outbreak of multi-drug-resistant Shigella, a harmful bacteria that gave more than half of the 12,700 participants severe gastrointestinal illness. Many people carried the infection home afterward, spreading it to other states. This earlier incident demonstrated how easily a similar outbreak could occur again under the same conditions. Public health workers also struggled with organizational barriers because the Rainbow family has no official leaders and operates on a voluntary, informal structure. Many attendees used pseudonyms, moved around constantly, and were suspicious of government involvement, which made it difficult to apply standard health monitoring procedures. Routine tasks like tracking illnesses, distributing information, or coordinating safety measures required flexibility and creative approaches because the community did not function like a typical event with clear points of authority or communication. For each large Rainbow family gathering, the U.S. Forest Service organized a specialized National Incident Management Team to oversee the situation because the events were so big, remote, and potentially risky. To keep all the different agencies working together smoothly, they set up a unified incident command system, which is a formal structure that brings public health officials, law enforcement, emergency medical services, and other partners under one coordinated leadership approach. This system ensured that everyone shared information, understood their roles, and followed the same plan, allowing the response to be organized and efficient despite the unusual setting and the enormous number of people involved. A wide range of agencies worked together to manage the gatherings, each bringing different expertise needed for such a large and remote event. Local, district, and state health departments handled disease prevention, sanitation concerns, water safety, and general public health guidance. Emergency medical services and nearby hospitals provided medical support, preparing for injuries, illnesses, and possible evacuations. Law enforcement agencies took the lead role in the overall command structure, coordinating activities across all partners and ensuring that every group operated within the same organized response system. The governors of Montana and Idaho issued local emergency declarations for the counties hosting the gatherings so that additional money and resources could be released quickly if needed. These declarations made it possible for public health teams, emergency responders, and other agencies to access funds for supplies, staffing, transportation, and any unexpected needs that might arise while managing such large, isolated events. Public health involvement at the gatherings required constant, hands-on work because the sites were so remote and lacked basic services. In Montana, county and state health workers, including a public health nurse and a sanitarian, entered the camp regularly, with one worker staying there full-time to monitor conditions, answer questions, and address health concerns as they arose. 2 or 3 additional workers hiked in every other day to check sanitation, observe food and water practices, and provide health education to attendees. In Idaho, the responsibility fell to the regional health districts, whose staff coordinated the public health response, monitored risks, and worked alongside other agencies to keep the gathering as safe as possible under the challenging circumstances. Both gatherings faced significant fire risks because drought conditions in Montana and Idaho, combined with hundreds of campfires used for cooking and warmth, created the possibility of a dangerous wildfire. Evacuation would have been extremely difficult since the only access routes were narrow, single-lane dirt roads that could not handle large numbers of people quickly. To prepare for the worst-case scenario, the U.S. Forest Service used satellite images to locate open areas that could serve as safety zones where attendees could retreat if a fire broke out. Public health workers then helped spread the word throughout the camps, making sure people knew where these zones were located and how the fire safety plan worked. Because radio and cell phones barely worked at the remote gathering sites, getting help for serious injuries or medical emergencies was difficult, so law enforcement mapped out specific spots where helicopters could land if someone needed to be airlifted out. At the Idaho gathering, helicopters were actually used 8 times for emergencies such as heart attacks, seizures, obstetric problems, major falls, and vehicle accidents. Public health workers supported these efforts by keeping the designated landing areas clear of tents, camps, and other structures so helicopters could reach patients quickly and safely whenever an evacuation was needed. Food safety was a major concern because more than 50 volunteer-run communal kitchens were preparing meals without refrigeration, thermometers, or any formal oversight, which increased the risk of food spoilage and contamination. Since these kitchens were not licensed or required to meet standard regulations, public health workers could not conduct official inspections, but they walked through the cooking areas to offer advice, encourage safer food practices, and help volunteers understand how to reduce the chances of people getting sick. Drinking water came from makeshift systems that carried stream water through plastic tubes from upstream sources, meaning everyone was relying on untreated surface water that could easily contain germs. In Montana, environmental health workers agreed to test the water after attendees asked for checks, and the lab results showed high levels of fecal coliforms, bacteria commonly found in surface water that has been exposed to grazing animals. Because the water was not safe to drink as it was, public health workers repeatedly urged people to boil it, treat it, or use proper filters to avoid getting sick. Sanitation at the gatherings relied on very basic setups, mainly open pit privies and shallow trench latrines that attendees dug themselves. These makeshift toilets were usually placed far enough from streams and cooking areas to reduce contamination risks, and simple signs made of cardboard or paper were posted on nearby trees explaining how to use lime or ash to cover waste. A few of the more heavily used latrines had improvised hand-washing stations made from containers filled with diluted bleach water, giving people at least a minimal way to clean their hands and reduce the spread of germs. The main source of medical care at the gatherings was a volunteer-run clinic called the Center for Alternative Living Medicine, or CALM. It operated around the clock and offered free basic health care, counseling, healing workshops, and herbal remedies. The people working there came from many backgrounds. Some were herbalists, faith healers, or acupuncturists, and only a few were trained in conventional medicine. Because the clinic was informal, no one needed official medical certification to treat patients, and the skill levels of the volunteers varied widely. Even so, CALM served as a central place where attendees could go for help with injuries or illnesses. On a typical day, CALM handled around 25 walk-in patients, dealing mostly with common problems that arise in large outdoor camps. These included stomach illnesses from food or water contamination, sprains and other soft tissue injuries from hiking or rough terrain, drug overdoses, dehydration, and sunburn. Although the clinic was not a traditional medical facility, it played an important role in meeting basic health needs in a remote environment where no other immediate care was available. Public health workers built a cooperative relationship with the CALM volunteers by visiting the clinic regularly, talking with staff, and offering help without judgment. Over time, this created mutual trust, and many Rainbow participants became open to receiving reliable health advice. Attendees were interested in learning how to avoid illness and stay safe in the remote camp environment, which made it easier for public health teams to share practical guidance. Because of this growing trust, CALM began inviting public health workers to give educational talks on health issues that worried attendees. These sessions covered topics such as tick-borne diseases, giardiasis from contaminated water, rabies risks, and hantavirus exposure in backcountry areas. Around a dozen CALM volunteers typically attended these brief trainings, asking questions and showing genuine interest. The volunteers also expressed a desire to continue these kinds of health education activities at future gatherings, reflecting the value they found in the partnership. Monitoring illness at the gatherings was difficult because many attendees used nicknames, moved around frequently, and had no fixed place to stay, which made it hard to identify people or check back on them later. There were no phones or permanent addresses to rely on, so normal methods of contact tracing could not be used. On top of that, CALM volunteers did not want to keep written records of patients' complaints, limiting the amount of formal data public health workers could gather about who was sick and with what symptoms. Despite these limits, public health workers still gathered useful information through informal conversations. During regular visits to CALM, they asked staff about how many people were coming in, what kinds of illnesses and injuries they were seeing, and whether any patterns suggested a possible outbreak. CALM staff were generally open to these discussions and shared what they were noticing, which gave public health teams a rough picture of health trends at the gathering even without written charts or electronic reports. To strengthen disease detection and improve safety, Montana health officials supplied CALM with stool specimen kits so that suspected cases of intestinal infections like giardiasis or shigellosis could be tested quickly. The state public health laboratory processed these samples at no cost, making it easier to confirm or rule outbreaks. Public health workers also provided sharps containers and biohazard bags so used needles and other medical waste could be disposed of more safely, reducing the risk of accidental injuries and contamination in the camp. Both the Montana and Idaho gatherings ended without any major disease outbreaks or public health emergencies, which was a notable achievement given the remote locations, lack of infrastructure, and very large crowds involved. Despite the high risks, ranging from unsafe water and basic sanitation to fire danger and limited medical access, the events were managed successfully, and the thousands of attendees were able to participate without experiencing widespread illness or serious health crises. This positive outcome resulted from strong cooperation among all the agencies involved. Public health teams, the Forest Service, law enforcement, EMS, hospitals, and on-site volunteers like those at CALM worked together under a unified command system that clearly defined responsibilities and kept communication organized. Public health workers remained flexible, respectful of the community's unconventional structure, and willing to adapt their methods to suit a setting with no leaders and minimal resources. This collaborative, open-minded approach made it possible to maintain safety and respond quickly to problems, demonstrating that coordinated teamwork is essential for managing large, isolated gatherings. The paper emphasizes that managing large, remote gatherings successfully depends on public health teams being flexible, working well with many different agencies, and understanding the unique culture and attitudes of the people attending the event. It stresses that health workers must be willing to operate within a unified command system, where all groups follow a shared structure and clear roles, so everyone can coordinate smoothly and respond effectively to problems. The overall message is that collaboration, adaptability, and cultural awareness are essential for keeping people safe in challenging, unconventional settings.